Aloha. Talofa. Yorana. Let's get started. All right. If we could go ahead and take our seats. Today's breakout session here is on best practices in engaging communities in health programs and research. If we could please have all our presenters for this session, please come up on stage here. Save some travel time. Well, we're trying to catch up on some time, so if we could have our presenters here up on stage. Again, the same format, we're going to read the bios, and if we could kind of please hold on to the questions for the Q&A to be at the end of the session here. We have Nayar, Marcella, Mr. Kawa. We need more chairs. Okay. The staff, if it's possible to get more chairs for the panel here. How many more chairs? There's one by Adam.
I think now we represent three. Let me see. 1, 2, 3.
Huh? Do you have PowerPoint? Two more. If we can get 2 more chairs, please. Thank you. So I'm going to go ahead and read the bios of our first group to present. Nayar Kabua is the program coordinator of a comprehensive cancer control program in the Republic of the Marshall Islands, where she works with Pacific Islander communities to implement strategies to increase screening and early diagnosis of cancer through community-based intervention. Marcella Jonathan Sakayo serves as the coordinator of EBI Distance Education Center of the College of the Marshall Islands. Ms. Jonathan Sakayo is a strong advocate for education and believes in educating as a way to promote change. Her professional interests focus on educating to promote a healthy lifestyle and living comfortably. She is involved in the DIAK coalitions on EBI, Kwajalein. It's E. Oh, EBI. Kwajalein Atoll, and serves as a secretary for the RMI Teacher Standard Licensing Board and EBI Catholic Schools Advisory Board. She has degrees in educational leadership and social work. Mr. Kawa Jadias is going to be here. He's here. He's coming to this. Yeah, he'll be here. Okay. Has a bachelor's degree in geography, specializing in environmental studies, and currently serves as mayor of Lib Island in the Republic of the Marshall Islands. He previously served as deputy general manager at the RMI Environmental Protection Authority in EBI. Mr. Jadias has also served as an employment counselor at ESL Tutor, where he had the opportunity to engage community members towards self-reliant strategies, teaching youth and adults to overcome obstacles. In 2014, he served as the president of the Lejoy Family Foundation. Ladies and gentlemen, as our first presenters, you have the floor. Welcome them, please. Thank you.
Can I borrow your glasses?
Do you need?
Just in case.
I'll leave it. Back up. Okay. How do I make it bigger?
This thing?
There we go.
Oh, what is that? Oh, okay.
Okay, and
Just
then
the
up and
video?
down. Yeah.
Okay.
Yakoy, everyone. My name is Niar Kabua, and I'm the coordinator for the cancer programs back home in Marshall Islands. And with me is Marcella. She will finish up my presentation with the big bang, Ibai bang. So my topic, Church to Clinic Cancer Screening Campaign. Back in 2015, we piloted and launched the Church to Clinic campaign to increase cancer screening using our national cancer screening guidelines. So the initial goal back when February 2015 was to cover 1,000 people, which included EBI. So from the data that we have, it's well known that cervical cancer is number one. We're actually number one in the world, the prevalence of cervical cancer deaths. Another data that we gathered were around 476 were registered in 2013 as having cancer. So here are our guidelines that I talked about. Guidelines work around cervical, breast, and colorectal with the resources we have, so those are our priorities. So you can see our screening rates are very low for cervical, breast, and colorectal. We just finished off our 5-year project, and back in June 29, 2017. So we have new projects which are also prioritizing these cancer screening. So our big challenge is having our ladies come in for early detection. So this is the avenue that we came up with, the Church to Clinic Cancer Screening campaign. Some barriers that we encountered in Majuro were scheduling the churches and the members to come into the clinics, transportation for clients. In Majuro, we got the women in, but our clinics were not ready. So in terms of staffing and resources, supplies, and health systems not in place. In Ibai was completely the opposite. The clinics were ready, but we were not able to get as many clients that we hoped. So here are some pictures. Our cancer survivors support group kind of lead our outreaches when we go to churches. They provide testimonies and the fact that the importance of early detection, because they share that they've been there and they don't want our people to go through what they went through. So it's really a strong way of advocating for early screening. In our outreaches, we also have healthcare providers that come with the group. So they provide education on cancer and risk factors and so forth. We also schedule screening on site versus referring individuals to the hospital to make appointments on their own. What is innovative? Working with faith-based organizations and the on-the-spot appointment settings. So this campaign came from was based on a research project done here for the Marshallese community and other Pacific Islanders conducted by Imi Hale. The knowledge that our culture is strongly built upon our spirituality, and faith-based organizations still play an important role in our communities. So with that, we also have our cancer support group helping with the outreach and education on early screening. So within that year that we piloted the project, we had help from Canvas Back Missions, which medical mission that come yearly, and they basically helped us with the numbers in increasing that year. About 602 women were screened within 2 weeks with this medical mission. So in Ibai, 3 churches they were able to go to 3 churches and register women also. The next process was evaluating the campaign. We conducted surveys to the churches that we visited, and mainly to capture effectiveness of presentations and how we registered and who came for screening and so forth. Lessons learned, we learned that we were able to bring the women in, but of course, like I stated, our healthcare systems were not ready for us. We even had the problem of having them limit how many clients we can bring into the healthcare system, the clinics. So since then, we've been trying to work with our Ministry of Health and the clinics, and we still continue to go to the churches, communities. The cancer support group and healthcare providers they go to the outer islands and also do the screening. They continue to do this activity. So for the next steps, we've developed the cancer survivorship plan back in year 4. It also has, we also developed the National Comprehensive Plan, and recently we've been granted the new FOA, which is a breast and cervical. So this initiative or campaign will continue with that. We will also cover Ibai and the outer islands in the breast and cervical cancer screening. So now I will call up on Marcella to talk about this beautiful island that you guys see up here and their activities.
Yahweh, everyone. I don't know what she wants me to say. She said everything. But anyway, just to let you know where we are, because they always say Nia is lying. There is no such island as Ibai. And some people call us eBay, so yeah, we own that company. We wish. Anyway, that's where we are, a little dot on the map there, the world globe. And that's basically Ibai. So as you can see, we don't have trees except the coconut trees and a few of them there. And when I came to Hawaii, I have allergies to trees. So that's why I have this swollen eye. I don't know how to do this. But like Near said, we weren't really successful at calling the ladies to come for screening because of a lot of stigmas and all that. If you're sick, you did something bad or something like that. But we went back as a coalition and think about other ways to do or means of doing something to get the ladies to come in. So I wanted to highlight on back home, the thing that ladies like to do is play bingos. So like yesterday, Dr. Richard said, you bring the service to the where the people are. So we kind of try to find out where the women are. So we made a bingo out of our, and the good thing about the funding coming to us instead of going through all the procedures with the government to explain what we're trying to do, the funding was there, and we were able to pull together the bingo. And before the bingo, we are a really good partner. We have good partnership with our the coalition. I mean, the community is. The coalition consists of mostly the community members, and we, aside from our full-time jobs, we meet every lunchtime. Nia doesn't pay us. She only pays the lunch. And that's where we meet because that's the only time we are free, and also in the evening. So actually, it's really popular at home. We work from the heart. So, and also trips like this, it's a good payoff. Anyway, the bingo, before the bingo, we had only 87 women that went for pap smears, screening, pap smears. And in the bingo, we had 10 prizes. The grand prize was $500. And the 9 prizes were a basin of fruits, kitchen utensils or wares, and a T-shirt, and a Panabin skirt. So we put all that in baskets and we played the games. And in between the games, we had promotion on the importance of screening, coming to the hospital. And if you have been there, bring a friend or two to come and screen. And also we also did promotion on cervical and breast cancer as well during the bingo. So a lady would get 20 cards free, and then if she wins, she's lucky she'll win one of the 10 prizes. Anyway, after the bingo, in the bingo we had about 400 ladies that showed up. And after the bingo, we had 500 plus ladies that went for pap smear screening. So that was the way to reach the ladies, and we hope to continue something like that again and we thank NAIR for writing a good grant that we're going to continue, and maybe more activities to get mostly the ladies that. And another good thing that came to our eBay Island is they did a mass screening, when was it, February? So we already have the data because the nurses and they hired people from the community to go house to house, get everybody to go and do the screening. So in the screening, I think they were able to not only, what do you call that, hypertension, but also diabetes and all that were in there. So it's a matter of gathering the data and see where it will take us or lead us to do our next activities. So even though we were not successful in the church to what is it? Clinic to church or something. We were able to get the ladies doing the bingo. So we'll look for something else that they like to do, and maybe picnic or something else. Thank you. That's what I wanted to add to the presentation from NAIR, because she did a really good job doing it. Pamoltada.
Okay, so I'm missing my team to help me with the distribution of gifts, and yeah, so I'm fired, I'm learning, but I want to do the due diligence of our cultural protocols and be able to. We might be on the unemployment list after this. Okay, moving on to our, and I apologize if we could please hold the questions, write them down. We want to be able to do a Q&A session after everybody presents. But I'm going to go on to our next presenters. Christina Shea has been the Deputy Chief, Director of Clinical Services at Richmond Area Multi-Services, Inc., RAMS for short, in San Francisco since 2008. Ms. Shea has been a member of the Asian Pacific Islander Health Parity Coalition since 2008 and co-chair since 2010. She is a strong advocate for underserved communities and continuously raises awareness about mental health issues, diligently works on efforts to address barriers of access to service, and is passionate about mentoring and promoting the next generation of bilingual and bicultural clinicians. Ms. Shea is a licensed marriage and family therapist and has been working clinically and administratively in the mental health field for 3 decades and with diverse communities in the San Francisco Bay Area. She received her Bachelor of Science degree in Human Development from University of California, Davis, and her Master's of Science degree in Clinical Counseling with an emphasis on marriage, family, and child counseling from California State University at Hayward. The next presenter, too, is Natalie Asun, MPH, directs the Asian Pacific Islander Mental Health Collaborative at RAMS, Inc., and also coordinates the Asian Pacific Islander Health Parity Coalition, including serving leadership role on San Francisco's Joint Health Equity Coalition. Natalie is co-chair and founding member of the Pacific Islander Task Force. She serves as a community board member of the Center for Youth Wellness. She has served the caucus director on the board of directors of the Asian Pacific Islander Caucus for Public Health. She earned her MPH from San Jose State University. Natalie previously worked as a program assistant for the Association of Asia Pacific Community Health Organizations, or APCHO, the Health Disparities Programs, providing programmatic and administrative support. Ladies and gentlemen, please welcome our next 2 presenters. Oh, yeah.
This one.
That one?
Yeah. So,
And then just up and down arrow.
okay, it's not coming on. It does at Queens Conference Center.
Why is it not coming up here? We get some technical assistance on, it's on the screen here, but not on the. Okay, we might get some help.
Someone's got it. Give it a second.
There. It's up there. Yeah. Okay.
And then just arrow up or down.
Yeah.
Yeah.
Okay.
Okay, we'll test it.
Which one is up and down? Just was, oh, okay. Okay, what am I supposed to say? Aloha, everyone. Okay. I need to know what I'm supposed to say. So I think we'll talk a little bit about RAMS, and then we'll talk about how we get to where we are. So I've been with RAMS for 18 years, and most of my job is talking about the clinical work, how Medicaid will pay for whatever, and clients care, and we serve basically cradle to grave. We have, is that a slide on RAMS later? And then I'll go backwards, of course. I never follow the slide. And in 2008, I was tasked to be on the API Health Parity Coalition. And it's like, okay, I have no idea what I'm supposed to do. So we just went to meetings and in California, there is Mental Health Services Act Prop 63. So in 2005, there was a proposition called Prop 63 that Californians voted for it. For people who make more than $1 million, it's a 1% tax that go into this pot. So a group of Asian and Pacific Islander providers came together and say, hey, we should advise the Department of Health to make sure that we don't get forgotten, because when it's aggregated data, we all look really good, and it doesn't go into the data that we have a lot of problem percentage-wise. So that's how API Health Parity Coalition created, and our job was to advise the Department of Health about the healthcare needs of the community. So it started in 2006. I think my boss was there, and then 2008 is Christina, why don't you go? So I did for a couple years, and then we have done the needs assessment among the Samoan community, and Natalie was helping on the other side with the Samoan community. And we also did the hippie education for the community providers. So 2012, we've been around for a few years. So we went to the Department of Health and say, hey, at that time, Barbara Garcia had just been promoted as the Director of Department of Health, the first non-medical doctor and very community-oriented thinking person to be the Director of Department of Health. So we went there and say, hey, we've been around for a while. What do you want us to do, and what's your priority? And she said, well, if I give you $50,000 for the Parity Coalition, would you do anti-stigma campaign on mental health? And so we said, well, sure. So we went to our community. So at that time, our communities included the Vietnamese, Cambodian, Chinese, Lao, Filipino, and Samoan. So we did 14 focus group with the elders, the youth, the families, the adults, and asked them about 3 questions. What's your point of view of mental wellness? What's mental illness? And what's the health-seeking behavior look like in your community? At the end of the day, we found out that I don't think it's a good, I don't think we are of service to the community if we just have a generic anti-stigma campaign and translate into different languages. Number one is we need workforce. How if we are successful? There's no workforce that serve this particular communities. And the other thing is we cannot do one and translate. It's just not fair to each community. We need to come from the community. However, because of this effort that we actually started the conversation with the communities were interested in continuing the conversation about talking about wellness. In whatever language that express, I mean, it's not the DSM, but it's the language in their own community that express what health or wellness means and what's the healing method in each community. So we continued this conversation, and then they are ready to tell the stories. So we went back and said, can you give us another $50,000 to create digital stories? So they gave us $50,000, and we did 14 digital stories in 6 different languages, including English. just talk about the story, the immigration trauma, their experience as an immigrant, the experience from the family of origin, just the story. And then, so under MHSA, like a pie, it needs to be divided into different areas of service. So there's workforce development, there is population focus, prevention, and early intervention. Under that, there's about $3 million under that piece of a pie. So African American, Latino, Chicano, Indigenous, LGBT, homeless population, all represented. But in San Francisco, 1/3 of the population are Asian and Pacific Islander. That group was not funded. And I went to the director of MHSA and said, what's wrong with this picture? She said, well, there was only one proposal and we didn't like that proposal, so it wasn't selected. And I said, wait, that is wrong. So we continued the conversation and we gave them the data of what the unofficial data of what we collected from the focus group. And there was a request for qualification out. So we applied. And we got it. And in the process of applying too, we work with 6 organizations that you're going to talk more about. I never follow PowerPoint. I suck at it. So sorry. I don't know what's on it. I just keep talking. And so we, about Rams. Okay. So about this, how we got into where we got into, oh, okay, that's Rams. But it's still about the API Health Parity Coalition. We work with the grassroots organization, and at that point we're deciding, should they apply it on their own to provide service for them, or should we come as a group? And at that point, we know that the smaller organizations don't have the infrastructure to get funding from the city because it's a big ball of bureaucracy and you need to go through a list of whatever to be able to contract with them. Plus, because it's a new contract, the fiscal year starting in July, the contract is not certified until like March of the next year. So you need to front the money for like 8 months before you even begin to be paid. So as grassroots organization that needs to pay the rents and payroll, it doesn't work. So RAMS has decided to be the lead organization to house this. And Natalie, okay, 5 more minutes, I was told. So Natalie become the coordinator. So she'll tell you more about how this, and we formed the API Mental Health Collaborative. And so, oh, okay, so Natalie told me that I need to tell about RAMS. So these are all the programs of RAMS. So API Mental Health Collaborative is part of Asian Family Institute. So it's, anyway, so these are all the different programs. But I think it's, yeah, okay. So we serve cradle to grave with adult outpatient clinic, which is, you know, for people who are on public insurance or no insurance, and it's, you know, traditional outpatient clinic, community mental health clinic. We have an adult residential facility. We have vocational services. We provide behavioral health services for people who are welfare to work with dependent and welfare to work without dependent. Free Out Project is where I started 18 years ago. It's a prevention early intervention program in the preschool. So we provide consultation at preschool and childcare centers and family daycare and family resource center, working with the adults, taking care of young children and prevent further, well, to identify issues and developmental issues that's related to mental health and early intervention. So we also have, we are American Psychological Association accredited training program. Also, we train other master level and doctoral level students in mental health. Our newest, and we are at all the high schools and the wellness centers. Our newest baby of the organization is a peer-based services. It's sort of like community workers, but we hire people with lived experience in mental illness. We have a peer certificate that we partner with San Francisco State University and with a 12 weeks, 3 units class that we teach them basic skill in counseling, how to be a peer counselor, and now we have a advanced certificate and monthly peer academy. That's how we create workforce in a more grassroots, and we also recruit heavily with our partners to apply so that we can create a beginning of a workforce in navigating the system and in peer counseling and the work. So what else am I supposed to say? Okay, that's boring. Again, a clinical program. We can skip that. I think Natalie is more interesting to talk more about our API Mental Health Collaborative, how our advocacy had formed into the baby that she has created.
All right. Thank you, Christina. I want to just, say something about the picture of Ibai that you had on there. In my previous work, I was with APJO, and a lot of our work we did with the Ibai with diabetes. So one of these days, I will make my way out to Ibai. But the focus of my work now is in the Bay Area, and I get to work with my own community, and that's the Samoan community. So our API Mental Health Collaborative, and this is a unique opportunity for an agency like RAMS, who provides comprehensive mental health services and programs, to partner with community organizations in the San Francisco Bay Area, in San Francisco. But I say Bay Area because a lot of our these communities that we partner with, do come across the bridge, to be part and participate in the programs that we, and the mental health promotion work that we do in San Francisco. So our community partners we have 3 work groups, and that's the Filipino Mental Health Initiative of San Francisco. There's a Filipino Mental Health Initiative in San Mateo County, and our Samoan Wellness Initiative, and our Southeast Asian Mental Health Initiative. And these are their postcard flyers for which they do their outreach programs. So when they're out in the community, we have events, they give these out as part of their promotion and outreach. The lead agency for the Filipino Mental Health Initiative is our Filipino American Development Foundation. And the Samoan Wellness Initiative is the Samoan Community Development Center. For our Southeast Asian work group, there are 4 agencies that center this work. It's the Cambodian Community Development Inc., the Laoseria Association, the Vietnamese Family Services Center, that primarily serve monolingual older adults Vietnamese, and the Vietnamese Community Development Center, and their focus is young people, youth, and transitional age youth. Our goals are such, to promote mental health wellness, increase the awareness of mental health, and reduce the stigma of mental illness. My background is in public health, so in the framing of this work, I wanted that component to be in there, to look at the wellness and how do we promote mental health in ways that are culturally relevant to our communities. And, something that's very familiar, because even the term mental health, when this project was in the pilot stage at the API Parity Coalition, a lot of people were, kind of iffy about, how do we, how can we even talk about mental health? We cannot even get to a primary physician. It's hard for us to find a medical home, a healthcare home. So we were very intentional in how to frame how we produce our goals, and this is in collaboration with our community partners. Our interventions, we have 4 out of the modalities that MHSA provide for all of our prevention, early intervention funding. We chose 4, and we do a lot of outreach and engagement. And the activities that are implemented to meet these interventions are community informed, and the community work on developing their own work plans. So we do a lot of cultural gatherings, festivals, celebrations. We do work group convening. We tell our partners, you reach out to your own community members and those who serve your community to be part of your work group, so that when you need to refer somebody to a service, those partnerships, come in handy. Because in San Francisco, there are so many services, so many people doing so many different things. For example, like yoga. So one of our community wanted to do their own yoga class, but, maybe a mile down the street, there's another organization that, have yoga classes. So we ask them, partner up, get to have the community go over there and do the yoga there, and vice versa. Hot Siva is one of our very hot wellness promotion activity, and encourage some of the San Francisco residents to go to our San Juan Community Development Center to participate in Hot Siva to promote mental health, mental wellness. We've had to develop our own tools because the tools that were available to our community were very hard for our community members to understand. The language of the clinical language is hard for them to understand. So we've had to develop our own resource tools and list. Our wellness promotion activities, we've developed our own psychoeducation curriculum, loosely based on the Achieving Whole Health curriculum, the mental first aid curriculum. So we kind of pull from different available models to build our own. And Christina mentioned that we also produce 14 digital stories. These are very short, 3-4-minute stories that we also developed a discussion guide to go with this very, very useful tool. And then we have service linkage. So we screen our community members, identify them. This is the non-clinical tool. They can say, we have in the screening assessment tool to say, who do you want to see? Do you want to go see a monk? Do you want to go see, whoever it is? So we are not just saying, you want to go to Rams. We also have a lot of options. How else do you define mental health, mental illness? How do you describe it? How do you experience it? So I'm going to quickly try to go through this list, but one of our achievements is our pilot program was actually funded, fully funded by the county, and the language of that RFP was exactly the language of the work that we did. And these are some of the things that we're trying to do across all of the work that we do in our communities in San Francisco, not just mental health. The formation of our group and sustaining them, and, creating our own workforce. A lot of our young people, now we look around, who is in college and how do we get a hold of them to come and be part of our work together? Some of our earlier panelists have mentioned social capital, and how do we create those? And creating our own evaluation tool and our glossary of mental health terms. So these are some of our objectives every year. We say we are going to outreach to 600 people, but this year we almost outreach and engage 60,000 people. So that we do very well in our work, even though our funding is not as much. Our community members have said you can give us $1 and we can drive 100 miles. So, we haven't done it literally, but the community partners we work with, they do deliver. Because our program is very new, our process evaluation, we want to know how many people have been reached and engaged, how many people have we screened and assessed and referred to services, and how many people are coming to our mental health wellness promotion activities. And, if you are going to be receiving this PowerPoint, these are just some of the qualitative experiences that participants mentioned. And our outcomes, so the outcome of our project is our outreach and engagement are so good, that people are coming to our community partners for services. And then our screening and assessment is so good that it would lead to our community partners being able to identify early on some of our community members who may be experiencing mental health issues. Our wellness promotion activities would be so good that it would lead to behavioral change. And then when we screen our folks, that we are able to refer them to services, and those services we also ideally we would want the service provider to reflect, the folks that we serve. And RAMS has done a very good job in recruiting a lot of our Pacific Islander CSWs and LMFTs, LCSW, PsyDs. As many of you, we have a lot of challenges, and data is one of those big ones. And my next group, we're going to be talking a lot about that, the lack of community reflected workforce, and just the underuse of the available services because of of how we experience and describe mental health, mental illness. Yeah, I think that's, thank you.
Thank you very much. Another round of applause for that group. Our next two speakers, I'm going to do an abbreviated bio just because I want to be mindful of the time that we have. It's right before lunch, and I don't want to be in the way of anybody's lunch. So our next two speakers, Ms. Tao Ve'e is currently the co-chair and co-founder of Pacific Islander Task Force in Northern California. Tao was the National Advisor on Pacific Islander Affairs and Program Officer on social justice work at the Asian Pacific Islander American Health Forum for 8 years. As an anchor institution for Kellogg Foundation American Healing Initiative, Tao led one of the Health Forum's anchor programs, Racial Equity Initiative, which she developed 5 collaborative partnerships made up of 26 community-based organizations across the nation. Our next presenter also is Sarah Tanuvasa, PhD faculty member at both San Francisco State University and City College of San Francisco, has taught undergraduate and graduate courses in subject areas including health, social justice, health policy, community health assessment, and public health fieldwork. In addition to teaching, Sarah overseen multiple CBPR projects that explore the connection between health and housing in the Bay Area. She serves as the Pacific Islander Task Force working with the Housing and Adolescent Health Subcommittee and is dedicated to combating health inequities through social justice, education, and community-led work. Ladies and gentlemen, welcome our two presenters. And Natalie is a jack of all trades. She's also going to be co-presenting in this group.
How do you put it up there? Oh, yeah. Okay, me again. So I am Natalie Asun, and I am the co-chair. Okay. I am now the co-chair of the the Regional Pacific Islander Task Force in the Bay Area. Okay. And we because we have a professor on our team, so we also want to do learning objectives. And one is to describe the role and responsibility of the task force, identify the strategies of the task force, describe the partnerships with county and city agencies to explore employment and training models, and also to describe partnership with county and city agencies to improve data collection and data reporting. So this is a photo. This is not all of the members of our Pacific Islanders Task Force, but these are some of us up here, and the three ladies in the middle with Lays are the directors of the health departments. From my right, Louise Rogers, she is the director of the health department in San Mateo County, and Barbara Garcia in the middle, she is the director of the health department in San Francisco, and Rebecca Gephardt, she is the Alameda County Deputy Director of Health, Director of Alameda County Health Systems. So why did we form the Pacific Islander Task Force? And from earlier presenters, I think we've also, that's the very theme why we created the task force. There was, in San Francisco, our community has been there for a very long time, but there's still a lack of knowledge about who are Pacific Islanders, where are they, where do they live, how did they come to the Bay Area. The disjointed systems that we have to navigate, there's fragmented services that are offered, not just our own community, but all of the small number communities in the Bay Area. Our community in the Bay Area is very transient. We move from county to county. We go across, as I've mentioned for the API Mental Health Collaborative, we have some folks that live all the way in Sacramento, and that's 2 hours away from San Francisco. And they travel all the way to San Francisco every Friday to be part of a cultural support group. So we are, and other factors that influence this trend is the expensive housing in our area. Data disaggregation, we all know without the numbers, we don't matter. It's like, well, there's only 5 of you compared to 5,000 Latinos, so we have to serve the Latinos, even though they may not have the disparities. And we just needed to take a different approach. We heard it from our earlier speakers, and some of our task force members have said, we are just tired of talking. We are tired of being studied. We want action. So, and we wanted to capitalize on all of the partnership and all of the networking that we've had in our different professional lives. And we wanted to transform how things are done for our community. So in 2015, we convened the task force. We tried in previous year to do the same thing, but our focus wasn't sharp. We had not, built that critical mass, and we were continuing to refine how do we, cultivate all of the strengths that our community has, to build this body where we can, really create change for the community. So our task force is regional in focus. For now, we are in San Francisco, San Mateo, and Alameda counties. And in the Bay Area, that is where most of us live, with most in Alameda County. Our process, it's community informed, community driven, and the process that is championed by health directors. We are very fortunate to have the buy-in and the friendship of the health directors in the Bay Area. So we've also wanted to identify a framework with which to guide our work. So we chose the life course model, and with that, it has the component of the social determinants of health. So in our meetings, we do a lot of, we do the cultural protocols, not the full-on cultural protocol, because that will probably take the half of the day just to do all that. And then we do spiritual blessing. And prior to all of our meetings, we meet beforehand to plan out the agenda for all of our meetings, which could also be a lot of work. So in part of our work, we identify a goal, and the primary reason, the goal is really to increase the visibility of our community. Really shine a light and say, we are here, and we've been waiting, we've been patient, and we are here to not only to let you know what our issues are, but also to say we are your tools. We are here to be partners in addressing the health needs and the social needs, and to take advantage of the assets that we have. And our purpose is just to serve as an advisor, serve as advisors to the health department. And that was our goal in the beginning, because our partners and the people that we know are in the health department. But certainly as we move along in our work, we are now looking at everything, at housing, everything that's under the social determinants of health umbrella. We've also been able to identify our priority needs, and priority one being housing. Housing is a big, big issue in the Bay Area. Recently, they came out with data. If you make $120,000, you are low income in the Bay Area. So that, and housing is extremely expensive. My priority number two is maternal, child, and adolescent health, and that's a big, big umbrella, and we've actually divided that in half because we are very mindful and aware that there's the health component, and then there's also, other factors outside of health that also impacts health, like education and youth development, and our young people being in the juvenile system. Our priority number three, mental behavioral health, and this is all issues that encompasses that big umbrella of a health issue. And our priority number four is population health. So anything that has to do with chronic diseases, we've categorized those in that priority area. And by default, data is part of all of our priority areas. We've also developed an administrative process just to make sure that, we're accountable to each other and the work that we do, and also to make sure that when our community members sign up for our task force, that we are, we can say these are some of the things that are expected of you and of each other. So we've created an administrative process. We also developed, we formed our subcommittees, and our subcommittees are made up of task force members, and everyone choose, like, if you work in this field, just go put yourself in the subcommittee that you feel your strength would be most utilized. And these are, we have a core group, myself, Tau, Leafata Moipeau, and Patsy Tito, and Jennifer Ava are part of that core group. The co-chairship that Tao and I are holding for now. And we just brought on a program coordinator for our task force, and we have our housing subcommittee, MCI, adolescent youth, mental behavioral health, population health, and our data subcommittee. That's one of our exciting additions. So our life course model, so we made it into, this is our iteration of what it looks like in our minds. It's a fale, and that's the Samoan word for house. And we chose this word because it reflects the life course of Pacific Islanders. And the way that we look at it to approach our work is in life stages. Rather than addressing health issues one at a time, we want to look at them in terms of, from birth to a certain age, from a certain age to a certain age. And we feel like that is more manageable than trying to address a lot of things one by one. In a typical Samoan fale, there are 4 pillars in the center. So we say those are our priority areas. The falas on the ground are some of the issues that we want to address to make sure those pillars, remain standing. And the bushes and the olpale fafu are some additional things that we need to work on to weave into the falas of our fale. So one of our colleagues also mentioned that there is a fonofale model out of New Zealand, that we're also looking at that as, to inform how do we, have the next iteration of our life course. With that, I'm going to be turning it over to my colleague, Sarah Wong King, to talk about our recommendations.
So one thing that's extremely unique about the Pacific Islander Task Force is that it is a body that consists of representatives from different health department agencies and representatives from the community who do work sort of on the ground and work with the Pacific Islander community and identify themselves as Pacific Islander. So it's a rather large body, you can imagine, but it includes the community voice, the representation of the public health workforce of Pacific Islanders, and also those who are leading some of these various agencies in the Department of Public Health across 3 counties. So it's a pretty unique infrastructure. And as Natalie talked about, one of the first things that we did as a large body was to form subcommittees to really tackle these public health issues, realizing that the scope is rather large, right? But that we do want to pay attention to the various issues and areas of Pacific Islander wellness. So each subcommittee that consists of individuals who do work in that field and those who work for government agencies in that same area came together. And it's really exciting. What some of the benefits of having this unique infrastructure are that the community-based decision-making process is happening. And we've had for a long time Pacific Islanders who do work in the public health workforce and in the field say, we're tired of, as Natalie mentioned, assessments. Our community has been over-assessed and the needs have been clearly stated. It's time for action. And at the same time, we have our local health departments who have said, we see the disparities and what should we do? What can we do, right? Which I think as a question can be sometimes problematic because it then puts the responsibility back on the community, even though the community has said, what do you mean, what can we do, right? But to have these 2 perspectives come together is very unique. You have the local government agencies saying, what can we do? And then the community who is working in the public health field saying, look, this is what the needs are. So the first work of each subcommittee has been to develop recommendations. And these recommendations have been based on experience, lived experience, work in the field, obviously also other methods of assessment such as surveys and community gatherings. And these recommendations are serve multiple purposes, and they really are addressed at the government agencies. Here are our recommendations. Here is what we need to see happen, and this is our work together. And the purpose of these recommendations, one is to turn a work plan into a demand, right? There's something very specific about saying, this is what we need to be doing versus this is actually what needs to happen, and you're going to work on this, right? So that was one purpose of the recommendations. Another was to influence and inform governmental processes and procedures, to advocate for the Pacific Islander community, to improve the government's understanding of the community needs, and also to really name and address the gaps in services and to put pressure to it to fill those gaps. So those were the purpose of developing recommendations. Each subcommittee then developed a set of recommendations to address their specific topical area. Now, even though they were targeted at the agencies that they work with or the agencies on those topics, there have been some cross-cutting recommendations. Not really surprising. Am I doing this right? Okay, there we go. There have been some cross-cutting recommendations, and they've come up in multiple subcommittees, and they really cover these 5 areas. I'm not going to go into too much depth, but one, and these are probably not shocking to many of you. One, representation. There have been plenty of recommendations around increasing the representation of Pacific Islanders in these governmental agencies, and that includes representation in leadership positions, that includes representation in decision-making bodies and processes. There also have been a set of recommendations around funding. In particular, the task force has taken on advocacy in funding for local organizations that are already existing. So we do have two longstanding Pacific Islander focused organizations, and the task force has really advocated in these various subcommittees for funding for those pre-existing organizations, really honoring the history of the work of our people. There obviously also are a set of recommendations around agency accountability and responsibility. We want to encourage our government health agencies to build their own capacity around supporting the community, to advocate and to be willing to engage in trainings, and to also, again, build capacity in many other ways. Of course, we have had some recommendations around data collection, really making sure that the data is accessible, that it's happening, that data collection processes are happening, but they're accessible to the community, that they're standardized, and that there's more of it so that agencies really have those, as Natalie was talking about, the numbers. And also, we want to make sure that the recommendations are about community needs. And across all subcommittees, what we've been hearing a lot about is space. And so we've had a set of recommendations around community needs for space that is specific to Pacific Islanders. So just a summary of some of the recommendations that we've seen cut across all subcommittees. And this is a more detailed list, not going to, again, go into detail, but you can see that we have recommendations for each subcommittee and then cross-cutting ones. Now, what you'll notice up here at the top, and Natalie also mentioned this, is that we have MCAH and MCI. And that is for a very specific reason. Is that okay? Yeah, I'm fine. So we found internally in our task force that the Maternal, Child, and Adolescent Health Department was not looking very specifically at our TAY youth, at our transitional age youth, and at our adolescent, and that there was a huge focus on maternal and infant well-being because of the high infant mortality rates in the Bay Area for Pacific Islander women. And while we wanted to make sure that those issues were held in our work, we also wanted to make sure that the community side of the task force was pushing systems to change to meet the needs of our community. And so we developed two subcommittees, one for maternal, child, adolescent health, maternal, child, infant health, and one for adolescent youth. And so those subcommittees are also aiming to navigate systems that weren't really made for people of color in mind, weren't really made for Pacific Islanders in mind, and to figure out how we can implement these recommendations in both of those areas. Also, our housing subcommittee, just to provide another example of the way that these recommendations are unfolding. Our housing subcommittee has done a lot of work in the area of representation. Even though Pacific Islanders, more specifically Samoans, are the second largest population in public housing in the Bay Area, there are very, very few Pacific Islander folks working in housing and health fields, or the intersection of health and housing. So what we've done as a result of these recommendations is really advocated for more positions in our public housing communities that are Pacific Islanders, able to meet the needs of the community. Whereas our housing authorities and housing agencies were not understanding the needs, they weren't understanding the documentation status of our community, they weren't understanding the processes of health and housing. We have really advocated for more positions that are dedicated to Pacific Islanders to better meet those needs and to bridge the gap with the communities living in public housing, subsidized housing, et cetera. So those are just some examples of how we've tried to bring these recommendations into fruition in partnership with our government agencies. And in our first phase of activities, we've reached a lot of wonderful milestones that Tao is now going to be talking about. Oh.
Thank you, Sarah. So, like Tana said, we don't like to be between you and lunch. So just to kind of wrap it up, I think one of the things that we're very proud of is that what impact have we made thus far? And we just started about a year and a half ago. Medical directors and the 3 county health directors said, we've never had communities approach us to look at doing business differently. Not only did we come and say we need to look at things differently, but here's what we'd like for you to do. So it was a thought partnership with these health directors. We had asked, and I think the wonderful thing was Barbara Garcia said, we can do better than that. We'll staff your task force for 1 year. Well, it was more than 1 year. that was a breakthrough for all of us. But what we never failed to do was take it back to the community. We said to the community, this is what's happening. We're making some, little progress. But a year and a half later, some milestone came up, and as you see up here, one thing that I like to point out is that we've already held 5 regional meetings, and these are all 5 regions of the 3 health counties, San Mateo, San Francisco, and also Alameda. A typical meeting would be like over 75 people because all of the health agencies are at the table, medical directors, all of the folks from maternal, child, and adolescent, and what have you. Not only that, but also the housing authority. We were, what our job was, we want to hear what you're doing with our community. And so how we respond is that we learn how to navigate the system by having this partnership. And with that, as we learned, we also learned that there were some programs that they had that we thought was going to be beneficial. So as Sarah mentioned, the highest infant mortality rate was in the county of Alameda. Was that an isolated case? No, it wasn't. It's all over in California. So we also identified, to give you an example, they have Black Infant Health. Wonderful program that was aligned across all 3 counties. One of our recommendations was, that looks like something we would like to adapt. So those are one of the recommendations, for example, that we would like to put forth. Another one is the California Department of Public Health. Through all of the regional meetings, we had directors hearing our cry and saying, this is what we need. From that, they said, hey, we have a really good relationship with the California Department of Public Health, data for maternal, child, and infant. Let's introduce you to them. Follow that relationship. Now they have volunteered to pull all of the Pacific Islander data for California. We had to be creative, right? So you pull the 5-year data. We have Dr. Sang from UC Berkeley, who's now overseeing our data research piece. Provided them with some measures. So we're really working together with the California Department of Public Health. Today, those data, we have that in our possession, and the data and research folks out at UC Berkeley are actually analyzing those. So we'll be coming up with a document along with our recommendations. So hopefully next year in Utah, we'll present that out to you folks. So again, the milestones, as you heard, we were able to identify the barriers, and we wanted to dismantle those barriers so that we can get through to the decision making. When we talk about having a seat at the table, well, this is what a seat at the table looks like, is really being able to identify the people with power and decision making, have a seat with them, discuss what we need to do, but don't just talk, come with a plan. And so we have 20 members of our task force, all come from all different walks of life, and a lot of them we were very intentional on bringing on board those who work in the county. We didn't want to say tri-county, then we set parameters. So the other good news with Barhai, that's the Bay Area, San Francisco Bay Area Regional Inequity Initiative. And so that's a collaborative of all health directors in the 11 counties up in the Bay Area. So recently we met with them, and they said, what are your asks? And then after we presented our model, they said, that's exactly aligning with our mission. And so our ask was, we would like for you to facilitate a meeting to expand the 3 counties to all of your 11 counties, because we really need to disaggregate the data between the Asian and Pacific Islander. It's still aggregated in California. And there's legislative, the federal mandate has already been out since 96? Yeah, that's a long time ago, right? Right, Uncle Hardy? Hardy championed that with a lot of our national leaders to really, look at the federal government, to be able to be in compliance with the OMB 15 mandate, to separate us. So 2000, that's when we saw, results from that. But still, California being the second largest state in the country with the largest population, we're still aggregated. That's dangerous. And so because that was part of our meetings, those 5 meetings, we really say, you know what, we cannot do business as usual. So now that directors know, they do believe that still aggregating the data between the Asian and Pacific Island is very dangerous. And so they will be our partners to really push so we can disaggregate the data throughout. So for us, what have we learned? We have learned that relationship is important. We can point the fingers on who to blame, but we have to do our part, folks. When we say you need to hire more people, make sure you have qualified people behind you. It happened before. We're over there saying, you gotta hire us, and then when the application came out, I looked backwards, all of them. Where are those who needed the job? So I think for us, we need to do our part. We need to take initiative. We need to be the thought partners. We can't point the fingers, but when we come with some solutions to our problems. We know ourselves better than anyone else. So for us, I think what we can say about the Regional Bay Area Pacific Islander Task Force, we're really here to create systemic change. And I think you have to be very systematic and very strategic. And please don't forget our youth. They are strong and they're very eager and hungry to really get involved, but also don't let them go. Hold on to them, right? So we're also happy to say that we have a pipeline. We have 4 students who are the interns with the UC Berkeley, so we have a partnership with them. And then we have more students, we're getting these emails this morning, there's like more students that want to join us. Also with Sarah's help, San Francisco State University, we also had interns from last year who also presented at one of the 5 meetings. So this is creating the pipeline as well. So engage them always. But for us overall, we've learned a lot. And there's still a lot to learn. And we completed all of our recommendations, folks. All those priorities up there, the recommendations are all complete. We didn't share it with you because now we're being strategic about, okay, counties, what can you do for us now? Now that we've delivered, now we're going to wait. So good news. In 2 weeks, we're meeting with the director of San Francisco. She wants to hear from us. What is it that you want? And then she meets with her directors. Alameda County, we've already met with them. And they're asking us to provide them a concept paper along with the Black Infant Health. What does that look like for you? What does success look like? How can you incorporate your culture in this program that's already in existence? So that's to give you a snapshot of the impactful and the actionable recommendations that we have developed in 1.5 years, guys. So we're so happy to be here, and we want to say much mahalo to NIA, the University of Arkansas, and also for Office of Minority Health. I don't know if Sam's in there. Thank you, Sam, for paying for us to get here. So with that, Faftai Lava, mahalo soy fu.
Again, thank you very much for the presentations. And of course, because we have lunch around the corner, we definitely encourage you to, for those who have questions, let's discuss that over lunch. I think the best communications are over lunch. You heard some of the strategies is around lunch. Yes. And then, the beauty is that you heard stories from both the Pacific and also the continental U.S. So I want to end this session with the audience participation and welcoming and thanking our presenters. And it's going to be, whenever I see Hardy, I always think canoe and paddling. So this one is going to be kind of like the wave. As I move my hand up, I want you to clap. As I move it down, a little more like a quiet clap. So the higher my hand goes, the louder your clap is. The lower it goes, so it's going to go back and forth, okay? So it's like the wave. So this is going to be the audience return for these wonderful presentations today, okay? So we ready for the participation? All right. Ready? Oh, you sharp, right? We all must be hungry, huh? Okay. One more round, one more round. And then the last one's going to be loud with some cheers and thanking our panelists. And we also, from the audience and from NIA and the university, we have some parting gifts for our presenters. So please make your way this way afterwards, okay? So we're going to go up, down, up, and then a loud yell, okay? Let everybody know that they should have came to this workshop. Okay? Ready? And yeah! Woo-hoo! Thank you very much. If you have questions, please, I encourage you to approach these beautiful ladies during lunch. Thank you. If you can come this way, we have some presents for you. You should have their names on.